Okay, so I think we should probably go ahead and get started, if everyone's ready. Um, my name is Isaac, for those of you who haven't met me yet. I work with a group called Frontline SMS Medic. It's using mobile phones in healthcare, sometimes connecting to OpenMRS. That's sort of one of our projects, but not the only one. And we had a meeting, a sort of breakout group discussion on the first day of the conference, on Sunday, about mobile projects. And there are people here, actually, who represent a bunch of great mobile projects. So it was a productive discussion. And we've brought up the notes here. So I thought to begin, it might be useful just for the new faces, for people who have done something with mobile, either as an implementer or maybe you're developing something. If you're working with OpenMRS and mobile, anything, whether it's phones, PDAs, maybe it would be helpful if you could come up here for a little bit, introduce yourself and give a 20-second introduction of kind of what your project is hoping to do. That'd be great. I can go ahead and start. So Frontline SMS is a platform for basically exchanging large groups of text messages. It's been around for several years. In the last few months, the platform released a feature called Forms. The focus is about making forms and structured data collection possible on the cheapest low-end Java-enabled phones possible. And so my group started using Frontline SMS in healthcare. Not doing a lot of robust decision support or anything like that, really just focused on communication in low infrastructure areas and then on capturing some of that data and making it useful later. So we're working to integrate with OpenMRS right now. It's a project we haven't finished yet. The first stage is for kind of reporting and data collection from the field, so remote health workers sending data to OpenMRS. And then stage 2, which I hope we can talk about later, is to have OpenMRS produce some messages that it wants to share and then have those automatically sent out to the field.
Say we're about JavaRS and then connection, then I'll talk about Comcare. JavaRS connections. Okay, thanks Isaac. My name's Kieran, I'm from Cell Life. We're working with Bart Start's project with another number of groups, Andy Cantor and Neil from D3, and we're looking at similar thing, but on the existing JavaRosa software, which some of you might have heard of, which works on just not the lowest cell phone, but the next cell phone up. Cell phones around $80 that run Java, and we're trying to replicate what OpenMRS, the basic data collection features of OpenMRS, but on the cell phone. So being able to get forms from OpenMRS, fill them out, send them back to the server, as well as register new patients or search for patients. So that's kind of going to start soon, and we hope to make that as easy and as quick to deploy as possible. So it might be in a module that people can just install into their current OpenMRS installation and get going, hopefully as quickly as possible.
Before we go any further, I forgot to find a note taker. Does anyone want to volunteer? Please. Anyone? All right. Thank you very much. Timekeeper, very easy job. Anyone?
I can do that.
Great. Okay. Go ahead, Ian.
Hi, and just to say that I think there are a few other groups, some represented here and some not, that are doing similar work that's very much in line with the JavaRosa connection to OpenMRS. The folks from Makerere, including Daniel, have got systems that author forms that could run on mobile clients. I think we're all pretty much using Xforms as our standard for representing the forms. And then there's another application which goes by various names, EpiHandy Mobile, PicoRosa, and OpenMRS Mobile sometimes. But it's a similar kind of thing that runs on, I think, also quite cheap phones, runs Java, takes those Xforms, and then submits them to OpenMRS. And there's another group, the Open Data Kit, that uses similar technology and can take an Xform and on the Google Android phones and can submit them. And we're all kind of planning to go through the module that Daniel's written so that we can get our X forms into OpenMRS. And then I work for a group called D-Tree that builds up on top of this technology to enable decision support by field workers or people in facilities. So we code up medical algorithms or simple protocols for community health workers to guide them through clinical encounters or household visits, and that data eventually will also go into OpenMRS, although we haven't done that yet.
So people working into the other mobile projects, you don't have to feel obligated to come up yet, but you certainly can. As you have ideas, just come up here, take a seat, grab a mic, and tell us what you have to say. Just to cover some of the really major points of our last meeting. So we first kind of talked about this idea of, I think we phrased it, what can OpenMRS do for mobile projects? Probably more appropriate to say, like, what can we do for each other using OpenMRS? But basically, you know, mobile phones, mobile devices in general are great for collecting all kinds of data in all kinds of places, but it's hard to manage that data in a really robust way or visualize it on the phone. And so there was, for obvious reasons, since this is the OpenMRS meeting, some consensus that OpenMRS can be kind of a meeting ground for mobile platforms. Some of them can't function without OpenMRS in a very, really, some of them like FrontlineSMS really are standalone systems, but they're not medical record systems, and so they can integrate with OpenMRS for, you know, clinical care. The next thing we talked about was sort of what mobiles can do for OpenMRS. So how can mobiles extend the features and use of OpenMRS? And you know, since we're really trying, we're here to figure out how we can collaborate more effectively. And so, as Neil mentioned, one of the first things we figured out was that, and I think we sort of already knew this, but there was definitely a lot we learned there, that Daniel's Xforms module is a great place for a lot of us to revolve around and collaborate around. So yeah, as mentioned, Java Rosa already uses those Xforms. FrontlineSMS is using those Xforms and translating them to Frontline forms, which work on less expensive phones, but it's the same point of interface with OpenMRS. And so hopefully we can build that out even more in the future, have it interact with mobile devices in a more and more intelligent way.
Can I take a moment to maybe poll the group here for what kind of requirements you have? So we hope to start a project soon with Cell Life where, you know, roughly speaking, you'd have OpenMRS running and you'd want to be able to collect data on cell phones instead of doing it in the standard way on desktops and have that data go back into OpenMRS just like it would otherwise. And so we're about to start that, and we hope to deliver a well-packaged system in the coming months to anyone doing OpenMRS installations. And so it'd be great. This would be a great point to get feedback on what you'd like to see in that. What are your key priorities?
Yeah, I have to participate in the fishbowl. That's bright. I'm gonna.
We can turn that off now.
Yeah. So I could speak. So I have a new role at Ampath, leading up its informatics endeavors, and one of the things that I would like to see, so in Ampath, the care has been very traditionally, mostly like almost 100% provided in the clinic. That is eroding now, and I think that's a good thing. The early parts of that are an initiative called HCT, in where instead of waiting for HIV positive patients to come in and identify themselves, they're actually proactively going out and identifying who might or might not be positive. They're doing actually tests in every home. And so literally for the dream is, so Ampath's catchment area is about 2 million people, and so they're ultimately going to be going out and providing HIV tests to every one of those individuals within the whole catchment area. And they're going to be collecting primary data against both the household and the individual. And so that's a project that we've been doing in collaboration with the Google folks, using Android phones and a lot of the basis, the OpenRosa stuff. So data collection is an obvious use case, I think, in being able to collect primary data that establishes a medical record. One of the other use cases, so
Can I ask you a question about that
Yeah.
use case, Paul, which is, so that's a lot of cases where the first encounter with the person is through the mobile. And do we need to worry about how patient IDs work through that? Is that worth elaborating on?
So actually, there's a lot of detail. Because this is the first encounter with most, we're actually giving people ID cards, unique IDs, and we're pre-generating cards that are laminated, and they have a barcode on them. And as part of the check-in or part of that process, we actually use the camera on the phone to scan the barcode. So we actually use that ID and then add that as a data point to the system. So we actually establish and we provide them with an ID, and that is the key, or one of the ways in which people will be able to get in. So subsequent visits, when they bring this AMPATH ID in, we'll scan the barcode, and that's what begins that process.
Super. That's great that Simon is taking notes, since he'll be part of this project. Not to press too much, but are you willing to take do you need to do anything special to verify that the person doesn't have a record in OpenMRS already, or just sort of ask them and that would be enough?
The plan that we have right now, and we're still kind of thinking through it, there's a team led by Sean Granis that's built a patient matching module, and so what we anticipate doing is in the background, like in a cron job, running those demographics against the other records to see if there is in fact a statistical probability that it's a match with a patient that already exists. And so that's at least the plan today.
Right, so in the household visit, you'll just give one out, and then maybe later you'll correct it.
Yes.
Is that right?
Yes.
And just to point out, this is I think one of the biggest differences to going to mobile is the fact that you're no longer connected to the patient database. That's easy when you're using InfoPath or something like that. You could just look people up right then before you enter data.
Right.
And in the mobile case, if you're disconnected, you have to collect all the data before and submit it when you haven't yet had that chance to look at the patient database.
Right. I mean, we're going to be doing some very basic kind of sniff tests. I mean, we're going to say, have you ever been to AMPATH before? And my guess is that, I mean, if people answer yes to that, then we can note that. And then that will also be kind of a seasoning to the statistical matching process. But one other use case that I want to talk about that more resonates with the Frontline SMS folks, we believe that HCT will be the first kind of outreach into the community, but then we have a much more elaborate thing that I actually just heard about before coming to this meeting, where we are going to be basically assigning community workers for this entire catchment area as well. And so we have this two-tiered approach with CORPS and CHOOSE. Those are basically acronyms for different types of community healthcare workers. The CORPS are kind of like the leaders, and there'll be one assigned for every 6,000 individuals, and then there'll be 3 CORPS assigned for, 3 CHOOSE for every 1 CORPS. So roughly each CHOO will be responsible for knowing 2,000 people and having a good relationship with them in the community, understanding their healthcare status. So it's a massive endeavor where literally the entire community of 2 million people, every 2,000 people will have 1 CHOO assigned to them. So today what we do when we try to measure adherence and we try to measure visit quality, so have people come to visits, is that we prospectively create cohorts, lists of people that haven't been to clinic in a specified period of time, and we create these lists, and then people actually go out and identify and find these people. They actually go out to their home. But in this world of CORPS and CHOOSE, one might envision, instead of having just the list and then actually having people manually go, that we could perhaps send SMS messages to the corresponding CHOO to notify them, so that it's a little bit more of an efficient way to communicate. And so from a technical perspective, it's a very simple thing, because we can generate the cohort of people, and if we have in our primary record the corresponding CHOO, then we can, instead of generating that list, generate a series of SMS messages that are targeted to the corresponding person. So it would be nice to have a generic mechanism where when we have some kind of a alert, or we have a cohort that we've built, to be able to go and create the corresponding SMS messages to go out to each of the healthcare workers.
So that gets right into the meat of where our discussion ended last time. And I think we had been, thinking of different ways to do this. Not sure whether it would be in Frontline SMS or in OpenMRS, and I think one of the things that we figured out, it just began to figure out last time, was that it's something that might be useful for multiple groups. So it might make sense to try to build it in OpenMRS, the logic service, and then have it exposed via probably XForms module, so that various groups could take advantage of it. So there are a couple different ways we could implement it, and what would be really helpful now is if we could get feedback from the various, groups that might implement it, also groups that might help build it, what you'd be interested in. So you mentioned, one way of doing it would be is if you already have a patient assigned to some kind of health worker. And so that assumes a few things, including that mainly the pre-existing relationship, basically. It assumes that the request for follow-up won't be the first sort of point of contact between some health worker and the patient. Another way of doing it would be to implement features like with GIS or the address hierarchy module, which I'm still beginning to understand, and have it where an individual health worker might have sort of their own mini catchment area as opposed to specific patients. And we could create some kind of logic within OpenMRS that would say, okay, here's our cohort of patients that need to be followed up, and then drill down for each individual patient and say, okay, the first patient in the list lives in this cell or this whatever. Who's the health worker responsible for that geographic area, and direct the SMS that way. What do other people think about that?
I just want to say very generically, I think a lot of the ability to send that alert out to that CHU is actually already there in OpenMRS. We'll have established the relationship between the patient and the CHU. That will be a relationship in the database. And we'll already have the demographic information for that user also in the system as well, because users are also people, and you can store as much demographics for each user as you'd like, which would include their cell phone number and that sort of thing. So what would be really nice is if we could reliably download something that would give us the ability, once we hooked up a phone and got the proper software, to be able to send a standard message to Frontline SMS that could be received and turned into an SMS out, right? So just a very simple, for this number, send this message. And if we could just have, if you tell us what the message is that Frontline SMS needs to receive, and that returns in an SMS message going out, just literally broker that very simple piece, that will create a lot of functionality right there. Just simply, what do you need us to send you in order for you to generate an SMS out? Just do that.
A slight variation might just be to have an OpenMRS module that has that functionality in it.
Yeah,
I don't think it's so that itself can send an SMS message. If you say here's a number and here's a message, and you've got the cell modem connect up, it could just send it out. Possibly taking code from any of the projects, either Frontline SMS or one of the other ones.
Good point. Yeah. Maybe the SMS related projects could agree upon what that messaging standard was, right? So Rapid SMS, Frontline SMS all agree on, if we want an outside system to communicate to us, this is the syntax in which we would accept, and we would be able to send out an SMS in response. And if you could coalesce on that, that would be a very good thing.
I think we sort of coalesced around the XForms module, and how it precisely will happen isn't all nailed down. But I think basically via XForms.
There might be some other bits about send this message and I want an acknowledgement or something like that.
Yeah.
So there might be some other structure we could put around about deliver this message and collect information back, or get an acknowledgement, or this and that we could probably do, and I think we haven't done yet. I think it's a good idea.
Establish the messaging standard and get everyone to agree to it. And I think that if you can do a service for the community, that would be it. Broker the relationships, get the other groups to agree to it, and publish that somewhere, and then get a couple of use cases that make it happen, and then it'll become real and it'll be used.
I think you were next, right? I was next. I just want to make sure the microphone doesn't get taken again. Yeah. So I have a question about use cases. We've been thinking about two use cases, one of which has to do with sort of follow-up care, with distributed care. The other of which has to do with sample acquisition for laboratory services. And the details of those use cases aren't that important to my question. What's important is we've been trying to get a handle on what are the attributes of use cases that are well suited for mobile technologies. And I've heard you guys describe or make reference to mobile technologies that are used or that are targeted for a variety of different platforms. So, you know, Android or iPhone kind of devices with 3-inch diagonal or 4-inch diagonal touch screens, whatever they are, or Java-enabled phones, or SMS as the underlying messaging platform. I also heard Paul describe sort of the attribute of whether an ID needs to be assigned, which I think is an interesting thing. And obviously it's related to lab sample acquisition also,
Yeah.
but it's not something that we'd thought about as an attribute of the use case. So I guess I'm kind of curious what kind of thinking there's been among the mobile platform people about what are the characteristics of a good use case for mobile devices. Is it different on different platforms, or is that all sort of heuristic at this point? Is it all just sort of let's try out different things and see which ones actually work, or, you know, we think this should work, so we'll give it a try?
So, yeah, Frontline SMS might be a place to start because it's the most bare bones. And so it's, you know, in the last week I've worked with Corps and CHUs and CHWs and VHWs and CBDAs and half a dozen other acronyms. They're basically all people who are mobile. They interact with patients outside the clinic walls. And I've taken to calling them just mobile health workers. And so at the most basic level, if you have people who are outside the clinic walls.
Actually, let me clarify one thing about my question. It's just we've tried to think about the nature of the interaction, right? So all of those people are mobile, I agree, but if their workflow involved filling out, I should have added demographic surveillance to that list of use cases. And if their workflow involved filling out a 50-page form, or simply knowing whether somebody was home or not, or doing IMAI guidelines, those seem like different characteristics, different types of information interactions. And so I don't want to cut you off too quickly, but good. Okay, yeah. So I think we've thought as much about sort of what the interaction is like, and that's why I'm curious if there's been thinking about, is 50 pages of forms on a Java phone too many or not?
It's too many.
Sounds like it.
Anything. Yeah, it's too many on paper too.
There must be something that's too many.
That was one of those leading questions.
So if you have a model of care where you have mobile health workers, then kind of regardless of how that health worker interacts with patients, there's going to be some level at which they want that health worker will interact with other health workers. And insofar as they're separated by distance, you find a use case for, at the very baseline, SMSs to coordinate who's going where, who's doing what where, and, you know, asking for simple help. Things like that.
The common denominator.
I think that's the common denominator,
Yeah.
and that's the majority of what we do, is getting that very baseline figured out. Then from there you can build on layers of complexity for the interaction between the patient and the provider, and it may start with like a simple form, and for us that's as far as we're focusing on, simple forms. Most of them don't have more than 20 fields.
Yeah, I mean, I think your point's a good one, right? So I've always kind of looked at it as the SMS is the very baseline. All devices that are attached to the phone system can do it. Data gathering is probably the next step, just data into a system. But the vision of the HCT project, when people are HIV positive, we might also want the device to serve as a window into the record. So literally, we'll be able to do data pulls from the medical record. So that would probably be the ultimate, where you actually need to see information about the patient and actually start providing care out there. So that, I mean, that's probably the most advanced level. But I think there's those three tiers, and I think the use cases all probably hinge on, do I just need to be alerted about something to basically get someone into the clinic, or to make them go out and do something? Do I need to gather information at the point of care, or then do I need to basically look at their data to make some kind of a healthcare decision on their behalf, right?
And do you or others have thoughts?
Sorry, do you or others have thoughts on how those tie to particular platforms or particular technologies? So obviously SMS at the lowest level, but if you're going to do records review, do you need do you need a big screen? Do you need a touch screen to interact?
Well, with the HCT project, we just assumed that we will eventually have a portal, and it's going to be a mobile version of OpenMRS, basically, right? I mean, it won't be OpenMRS on the device, but it will be able to, once a patient will basically get a dump of all of their data and insert it into the phone and have a little data object in there that you can look at. So I think the richer, the farther you go up that pathway, the more sophisticated device you need. I mean, so I think to be able to review data requires a much different form factor. Simple data entry, like Frontline forms, you could potentially, if you're just really simple questions, not a rich questionnaire, it's probably, I play with Frontline forms, and I mean, it's good for what it does, but if you want to do a rich, like an HCT questionnaire, it would be impossible on Frontline forms, because it's got a bunch of branching logic, and it's it's a 100-question instrument, so it's a much different paradigm.
So then, is there a logical boundary between an Android or iPhone type device and a netbook with a built-in GPRS modem? It seems like that's the next level of mobile device.
Can I just, are you going to change the subject, or if you're going to?
Well, I'll add to it and then I'll change it, so
Okay.
why don't you go ahead?
So, it's careful. We have to be careful, I guess, because we're kind of a geek squad here too. Where we're pushing the technology and the use cases. I think from the Millennium Villages approach, which is we deal with community health workers. Each community health worker is responsible for 200 households, so only about 1,000, and we're even finding that is probably too many. So the numbers of humans necessary to participate in the system to do the kinds of functions we want in the field is very high, which means there's going to be a lot of phones, and they're going to be cheap phones, $40 phones or less. So the actual use cases are being driven in a lot of cases by cost, by policies, and also by what the specific needs of those communities are. So, for example, in Kenya, we're using rapid SMS to do surveillance work on malnutrition. We're doing that to manage the rapid diagnostic tests for malaria, and also for managing stock of drugs between community health workers. And there's lots of interactions that occur between the actual community health workers. Like, for example, I'm out of my coartem, can I text the next community health worker to see do they have any left or in their system, and what's their stock, and that can be all automated. I think that those kinds of things are going to drive this forward, and so I would actually like to have some sort of repository of use cases in a way where we could put the different ones up and how we're using the different technologies. And the only thing I guess I would add, to not really change the subject, but in addition to the XForm piece, which kind of governs the data collection back and forth, I think these sort of workflow issues about notifications, acknowledgments, did you do what you said you were going to do, or do I need to send somebody else out? I mean, I think all of those things would be really helpful to have captured and added to the standard communication.
Yeah.
To add to the clarification between different instruments and devices, essentially, if it's an approach where the patient has to provide us information, they probably aren't going to have the Java-enabled the Java-enabled direct phones, and so probably a structured SMS would be the approach to
Yeah.
get the information in. If it's a if it's a treatment supporter going house to house, you can probably provide the $80 phone to go house to house and collect the data. To kind of change it to the experience I've had. So we have essentially implemented OpenMRS mobile, and the issue about essential like basic patient information or ID matching, etc. There is an option on there to search for the patient through GPRS from the field.
Oh, cool.
So I can enter an ID or a name, and
You get back a response.
if it isn't in the initial downloaded cohort, it'll go to the server and bring that patient up.
That's probably even better than what we did, right? Which was just to, ask the question, and if they say no, then we give them so you're actually doing a hit against the server, getting back a response.
Exactly.
And then if you get one of those, you pick it, and perhaps you get the vector of the demographic information with that, so you then populate those parts of the
profile
form.
of the
Yeah.
name, age, address.
That's cool. That's very cool.
etc. So that's already there.
Yeah. So just to let you know, for the HCT, it's a whole cost issue. We don't want to put SIM cards and have to pay for cell service yet,
For
right?
GPRS, okay.
Yeah, but we need to understand a little bit more what the actual costs are. I think it's a perceived worry and it's not actual, so we haven't gone through that yet.
Well, I was just going to ask you. I was going to ask you that question. You're not using GPRS, or in Eldred, is there coverage for it? I mean, is it kind of possible?
Yeah.
Or how are you getting the data on the mount?
Yeah, so what we're doing is we're using Android devices like a glorified PDA, basically, because it has the GPS, it has the camera. So what we're doing is we're actually using the wireless functionality. When they come back, they're going to wirelessly sync the results and basically dump the forms. Is Sam and Bugwa, are you here? Yeah, so Sam is the Kenyan that's been working on it with the Google team. So you should definitely, actually Sam, can you come up and talk a little bit about it? Kenyan powered.
Yeah, so basically what we are doing, we are using Android phones. And the reason we chose Android is because we wanted to do barcode scanning. We wanted to do some GPS without having a separate GPS device for that. So, and then one more power that Android gave us is that we can do a wireless sync without necessarily having to connect. So previously with the PDS, the counselors had to come from the field, then data managers has to use cables to sync data. Currently what we do is that they come in, as long as they have a wireless connection to the sync server, then they can do a sync. The next step that we want to take that into, once we have good GPRS coverage in Kenya, we may have to submit data right from the field. It's still something that is in our vision, not yet covered.
I think one of the things we didn't get to last time was a kind of specific talk about what devices people are using and what's appropriate where. And I think everybody has a different version of cheap. I've heard like 180, there's a new cheap GPRS phone, it's only $180. So I just wanted to say, like, this phone I have here, like, we bought these recycled in bulk for about $9 a piece, and they run the Frontline forms. So for us, under around $10 is what we think of as cheap, and they do the simple forms. I've never tried a form with 100 fields, so I actually don't know whether or not it would work. I know
you have it here. You make sure that he sees it before you leave.
I'd like to see it too.
maybe we should set up a demo time.
Yeah.
That would be cool. I'll come.
I'll come too.
I'll come too.
Dinner?
After dinner. After dinner.
Yeah.
After dinner.
Sure.
Cool. Up here then?
Yeah. Mobile fair.
What time does dinner end?
Usually like 8, 7.
Okay. So 8:15 mobile fair?
Yeah.
Good, sounds great. Can I bring up a new topic, which is one of the last things we talked about at the mobile session last time. I thought, it's not something I work on at all, but I thought was really interesting, was using mobile phones to open up OpenMRS or other EMRs to be more patient-centered. And so there's obviously some complications with privacy, although I think there's some ways you can solve it. But can you let people with phones, which is a growing group, be able to do queries like, when is my next appointment, what were my lab results, and somehow let people get more information from it. And it seems like, we talked about it for about only a few minutes, but it seemed like there were some simple things you can do that would be pretty powerful already. So I'm curious what people's thoughts are, and all.
I can talk about one specific use case that maybe doesn't fully realize what your vision is, but we're going to be providing a fairly comprehensive diabetes management within AMPATH. And the obvious thing that is this recurring data point that needs to be fed back is blood glucose. And so what we intend to do is to teach patients how to send blood glucose readings to the system so that we can get back those values, and then when they come in for their visit, be able to plot their graphs and see how their management has been compared to the insulin dose. But one could imagine, once they're taught to do that, then they could also potentially be given an option of maybe even getting some feedback themselves before the visit as to how they're doing, which would be really interesting, right? So I think that's a little bit of what you're getting at, and we will be doing that in the next year with an AMPATH, do the blood glucose stuff. So that would be another use case talk with the frontline guys about.
Another idea that I have to share, Joanne from Google gets all the credit, but it was actually at lunch a couple days ago. We were talking about how patients frequently move around and they transfer in and out of health centers, and in many cases we sort of just expect them to keep their own health record in these little paper books. And she had the idea that if we're keeping phone numbers in OpenMRS, it would actually be very simple to write a little service where they can send an SMS to the hospital number or whatever, and it would just auto return their enrollment number in any given program, or if there's a unique ID across the hospital system, just so that when they're if you have a place with multiple institutions, people may be hard to find, they may be for whatever reason, if you could just text in and receive your own hospital ID, that would, for me, be hugely useful in the ART clinic where I work.
Yeah, I think that would also have like security issues. If the mobile phone got stolen and anyone could send it, then I don't know, maybe there'll be an ethical issue with that.
So Columbia University and Grameen Foundation is working on a project in Ghana, and one of our key things that we'd like to address is messages to the patient. And we're finding the modeling of that, and the messages to the patient will be based on the state of the patient in the database. And to start out with, we're only concerned with immunizations and the service delivery, health service delivery for that patient. And in Ghana, there's a schedule of this service delivery that's the ideal. It's forcing us to model the state of a patient in what's turning out to be, I don't want to say complex, but interesting. And as an example, if I can give a scenario, a mother gets visited, and then what we can do is we can calculate when the next visit for that mother should be. So what that's going to require is a process in the background in OpenMRS that's looking for when the next thing should happen. So when that visit to the next mother should happen, we send out a message to the mother in some form, and we're working on what the form of that message will be, that says, here's when your next visit should be. Suppose that the mother doesn't go to the clinic at that point. When do you respond to that mother? Maybe it's 3 weeks, so that's part of the complication. Suppose that the woman doesn't come in. What message do you send to the health service, worker, the community health worker? Finally, what we do is we send 3 or 4, and again, increasing the complexity of these messages. We send 3 or 4 messages, then they're not delivered. The phone's off or something. Then that number becomes out of service. Also, what we're realizing is if we're going to be sending these messages, it's possible that the user has preferences for when these messages are sent. And again, so it's requiring us to think very carefully about the state of the patient in the database and how that state changes as messages are sent from the patient to the patient, and the patient interacts with the health service delivery.
Last couple of health conferences I've been to in South Africa, there's been a lot of, perhaps from corporate companies as well, but there's been a lot of pumping of, self-owned patient records, basically like Google Health, and access to that. And I've heard around, a few other projects in Africa about the patients have this health passport that they might keep themselves, that's their own medical record. I was just wondering if, we've talked a lot about, health services in the area coming down into the community and providing services and sending data back to their system. I was wondering if anyone else is interested or heard about stuff about maybe people having their own access to their own records via their cell phones, whether that was a good idea or not.
There's certainly no reason why with proper authorization, you couldn't give a copy of the data that's been collected from a record system back to the patient. The main issues with that oftentimes are one of the interpretation of the content, right? So the experiments in the U.S. around getting patients their own information might be different than Africa, but it tends to, at times, create anxiety because a value that really is called abnormal in a conventional sense doesn't really have a clinical significance, and so there are a lot of considerations that one needs to make when making those data available. But I think the main thing to point out though is that it shouldn't be one or the other, right? So when we talk about it shouldn't be that it's only a patient record system or a personal health record, or it's only an electronic medical record system. The data, in my opinion, should be stored in both, right? Because there are very clear values to having the aggregated information for being able to provide, analysis purposes, and also be able to compare some patient care to other patient care. But then there's also a real value in letting patients manage their own records so that if they go into other environments where they want to augment and add their own personal information to it that's private to them, they should have the ability to kind of augment that record as well. So I think there's some real opportunities there, and OpenMRS, I can say, is committed to establishing personal health records. One of the projects that we talked about with Google is actually a cooperative one in Ghana, where we would imagine that Google Health would be the patient-facing side of the interface, and OpenMRS would be the clinician-facing side. And you could imagine that the data could commingle between those two pretty well. So, yeah.
I would just, to follow up on that, if you're interested in building that, Google.org is interested too.
Yeah.
So,
Period.
follow up on that.
Just a question from what the lady said. I was wondering, is that a lot of the geographical linkages that are important, and I'm just interested in the $10 phone versus the $200 phone issue, which I think is going to be a critical one. How much of the higher order functionality that you want could be done by building a stronger data support services through the server side? So if you're using very simple messages or codes, or I'm not a phone person here, but to go back to the server that then ties into other complex databases that link the patient to geographical areas, to other kinds of things. And if you design that correctly, you don't necessarily need to go up to the higher expensive phone, that then does a lot of that stuff on the phone itself in terms of collecting a GPS pointer, being able to put complex forms or so on. What experience do you folks have in terms of trying to put more of the onus of the processing on the server side of things rather than on the phone side of things, and then deciding where the cost balance is in terms of making those decisions?
2 minutes.
I think that actually that is a very good point, and there's been two different camps about that point, because it really depends on connectivity. If you've got good connectivity, then the stuff can stay on the server. If you're having to run autonomously without good connectivity, either for cost or for connectivity reasons, you need to have more on the phone. But I think this actually, I wanted to make this point earlier and I forgot, but I think deciding where that intelligence should be on the server side is also not clear, whether it should be within OpenMRS or whether or not it should be within our partners. And the data certainly is going to reside, or most of the data should reside probably in the architecture of OpenMRS or that larger database. But the decision support that's used for workflow or for interpreting the queries or triggering, do we build that into the logic service, or do we really just put the data over to Frontline or RapidSMS or someone, and they calculate whether the triggers should go and the reminders should go? And I think that's another part of that standard communication I think needs to be clarified. Either it needs to be both, which probably the answer is both, but if, can we start with one or the other?
So, in our program for MDRTB, we essentially have treatment supporters go to the individual's household to monitor consumption of the drugs. It helps us to have the GPS capability on the client, so that we are also able to monitor if they actually attended that person's household. They could easily be at home entering data and getting paid, but we really want the treatment supporter there. So in our case, we need the client-side functionality.
There are a lot of things that people kind of assume you need smartphones for that I don't think you necessarily do. But there are some very tangible steps as patient interactions get more complex. Doing things like GPS, sending video and photos. It's often assumed that you need like a more robust phone to send longer forms, and I don't actually know. I've never like maxed out Frontline forms, so that's why I'm not contesting these claims that you can't put 100 fields on a Frontline form. But I'm not sure that's the case. We just haven't had that use case, so I've never tried it. And even if it's not possible just yet, I think it's feasible that it could be possible on the lower end Java-enabled phones. To follow up on some of Andy's comments, I think, I hope, it seemed like the general impression from especially the last meeting, also this one, is that we would like to try to get a lot of that logic sort of on OpenMRS, because that's the easiest way for us to share it and collaborate on it. If we can, but there are certainly some things probably that would be easier. For example, in Frontline SMS, one of them is just managing contacts. You can technically store phone numbers in OpenMRS, but Frontline SMS has a really very easy to use and complete interface for creating groups of phone numbers and for managing those phone numbers, and that's something that's not really worth rebuilding.